Hereby, I open this academic ceremony in which Gamze Erzin will defend the academic thesis utilizing exposome score for schizophrenia to predict mental health outcomes. May I invite you to present a summary of your study and the conclusions of your thesis? The floor is yours.
Thank you, Rector. Today I will present, I will start. Thank you, Rector. Dear Rector, dear my Corner team members, dear my supervisor, dear my friends. Today I will present to you the summary of my thesis. The title of my thesis is Utilizing Exposome Score for Schizophrenia to Predict Mental Health Outcomes. As a first, I would like to start with psychosis spectrum disorder, because in my thesis, we use different data sets, such as they include schizophrenia and first episode psychosis. And I mentioned that as a first, what is psychosis spectrum disorder? Psychosis spectrum disorder is a diagnostic umbrella, and it captures broad range from subtle psychosis experience to schizophrenia. And it is not rare. We can see psychosis spectrum prevalence in population approximately 3%. This ratio for schizophrenia is 1%. Absolutely, this ratio change depends on population. And schizophrenia is the most severe outcome of psychosis spectrum. And what is schizophrenia? According to DSM-5, this is classification book of psychiatric disorder. Schizophrenia has a lot of different symptoms. And one of them, hallucination. They can hear some strange voice. And the second one can be delusion. They can have some unreal thoughts. And they can have disorganized speech, disorganized or catatonic behavior, and negative symptoms such as lack of motivation and anhedonia. And to make diagnosis for schizophrenia, two of these symptoms should be present more than 1 month. And in my thesis, I focus on as a first schizophrenia and other psychosis spectrum disorder. And what is the reason of this important disorder? And in other words, what causes schizophrenia? And the reason of schizophrenia is not clearly understood, but genetic vulnerability and environmental exposures and their interaction are held responsible for schizophrenia. And this environmental exposure increase the risk of schizophrenia, increase the risk for schizophrenia, such as obstetric complications. We can give some example for that. Complication of delivery, complication of pregnancy, abnormal fetal growth, we can say. And also cannabis use is a risk factor for schizophrenia. Childhood adversities such as physical abuse, sexual abuse, physical neglect, they are also a risk factor for schizophrenia. And season of birth is important, also increase the risk for schizophrenia. Burning in winter for North Hemisphere is a risk factor. Hearing impairment, urbanicity, they are also the other risk factor for schizophrenia. Why do we focus on environmental exposures? Because they are important and they are potentially modifiable and preventable. For example, obstetric complications ratio and cannabis use can be reduced by taking some measures. And we need a score for evaluating environmental exposures effect. And in my thesis, I focus on this environmental score. And evaluating environmental score, we need to take into account some features about schizophrenia, such as they have correlation each other. The first figure shows that cannabis use has correlation with psychosis, tobacco use, urbanicity, childhood trauma. And second figure shows us childhood trauma has correlation with psychosis, also tobacco use and urbanicity. The big figure shows us most of environmental exposure are correlate each other. Some of them strongly, some of them weakly, some of them are negatively, some of them are positively. And the first part of my thesis, we focus on what is exposome score, how to calculate exposome score, and predictive performance of exposome score. Exposome is all non-genetic factors from conception onwards, and we can give an example for exposome, such as drug use and air pollution. For internal exposome, and internal exposome, gut microbiota, and DNA mutations. And we call this environmental score as exposome score because we take into account some features, some important features about environmental exposures, like they correlate each other and their weights are different each other. For example, emotional abuse can have a greater risk than bullying for schizophrenia, and we combined all environmental exposure. They include our data set, cannabis use, childhood adversities, hearing impairment, and winter birth. And as a first, we investigated the discriminative function of exposome score. And we use Netherlands mental health survey and incidence study data set. And we investigate this environmental score has a beneficial or not for identifying schizophrenia from general population. And this exposome score has beneficial for identifying schizophrenia from the general population. And after that, we try to understand this score has a relation to a psychosis risk. And we divided our data set 5 groups according to their psychosis risk, from no risk to clinical psychosis. And there is an association between exposome score and psychosis risk. In clinical psychosis, they have highest exposome score. And we thought that exposome score can relate it to broad psychopathology, not only for schizophrenia. And we found that exposome score has association with also bipolar disorder and alcohol dependence. But the highest association with exposome score in schizophrenia group. And we know that these risk factors, these environmental exposures for schizophrenia is not only related, is not specific for schizophrenia. They are also related to physical health. And also exposome score has association with ulcers, chronic obstructive pulmonary disease, intestinal disorder, and asthma. In the second part of my thesis, we examined the relationship between this score, this exposome score, and the dark side of psychosis spectrum. This is functional impairment. As functional impairment for psychosis is not an exception, it is a rule. And they have functional impairment different area, such as workplace. In their workplace, they can lose their job. Also in their relation with their relatives, and in self-care. And as a researcher or as a clinician, we should keep it in our mind. This treatment of schizophrenia or psychosis is not only improvement of symptomatology, also we should improve and develop, and we have to about their functional impairments. for this reason, we should deeply understand how functional impairment occurs. And to investigate the association between exposome score and functional impairment, we used two data sets. One of them UGI data set for analyzing our results. The group data set we used for replicated our results. And UGI data set consists of schizophrenia, siblings, and health controls and are three different countries, Serbia, Turkey, and Spain. And as the first, we found that as expected, because we know in schizophrenia group has highest exposome score and the lowest functioning compared to other groups, and in health controls has the lowest exposome score and highest functioning score. And the highest exposome score is associated with functional impairment, poor functioning. When we adjusted the results, genetic score, our results remain same. And we can say our results cannot be reduced by genetic differences. And we replicated our results in group data set. Also, the exposome score has associated with poor functioning in schizophrenia. And as I mentioned before, psychosis spectrum disorder is a broad range, and it includes a lot of various psychoses. And first episode psychosis is one of them. And we use Athens group data set. This data set includes 225 first episode psychosis. This data set has some limitation and some strengths, like they have measurements at baseline and 1 month follow-up, but in their data set don't include hearing impairment, but likely they have offsetting complication data, clinical features, and socio-demographic features data. And exposome score at baseline and at 1 month follow-up associated with poor functioning. And at baseline, functional score was 40. At 1 month follow-up, functioning score was 60. And we can say there is a functioning improvement. And I mentioned before, these are related to exposome score. And we can say poor functioning is associated with exposome score. But this functional impairment was not depends exposome score. And we calculate their symptom severity. At baseline, their symptom severity was high, approximately 100. But 1 month follow-up, their symptom severity decreased, like 60. But we found that this symptom severity at baseline and 1 month follow-up are not related to exposome score. But these symptom severity improvements, also we can say clinical improvement, has related to exposome score. And we can adjust our results with offsetting complications. Our results remain same. After that clinical feature, our results remain same. And migration ethnicity, our result remains same. And we can say this, yes, we can add some environmental exposures to estimate the exposome score, but after our results remain same, maybe we can't reduce this other risk factor, our results. As conclusion, exposome score can be beneficial for discriminating individuals with schizophrenia from general population. Exposome score has related to mental health and physical health. exposome score is associated with poor functioning and clinical improvement. And in future, we need longer follow-up studies, and we identify new environmental exposures. Also, we should take into account protective factors to improve exposome score effects, and such as physical exercise. And thank you very much for your attention.
Thank you for your nice presentation. The opposition will be opened by Professor Dr. Therese van Amersfoort. She is a professor of transitional psychiatry, sorry for that, of our Maastricht University. And she was also the chair of the assessment committee.
Thank you. Dear candidate, congratulations with your very impressive PhD thesis and also with your nice presentation. And I also extend my congratulations to your supervisors. You have developed and tested a very innovative approach to describe environmental liability for psychosis in particular. You use different clinical cohorts and you confirmed your findings in the different cohorts. And you conclude that the exposome score is a more accurate predictor for clinical diagnosis and functional outcome than, for example, meta-analytic or separate environmental scores summed up. And your work also emphasizes the need for a more holistic approach and integrate environmental factors structurally in the world of psychiatry and psychiatric research. I really, really like that. However, although it gives a lot of insight into the etiology of psychosis, and I'm not here only to give you compliments, but also to discuss some other aspects of your thesis. And you are a clinician as well, like myself, and I would like to know how you see this nice and sound theoretical model of exposome score be useful. How do you see it useful for clinical practice? How can you foresee this being translated? Because you also state that the environmental risk factors, in contrast to the genetic ones, are modifiable and can be used for prevention. Could you share your thoughts with me on that?
Thank you for this question, highly esteemed opponent. Yeah, actually, we aim to start to this thesis. There's a improving the score for using in clinical perspective, clinical area, but we should improve more for it. But we can say this score can be useful for identifying high-risk psychosis group also, because this is individual risk score, and we can think, yeah, this patients or this individual has higher exposome score. We should be aware for them, because they can have some physical outcomes. They can have the other broad psychopathology, and they can have also psychosis risk more than the other groups, because no risk groups has lower exposome score, and clinical psychosis group has highest exposome score. And we can say maybe sometimes we decided to which patients should take medicine, which patient only low dose medicine, and we can also find this score is related to clinical improvement. If we know that this patient has higher score, maybe we can give high dose antipsychotic drug, or we can know that this patient has low exposome score, we can give low dose. This may be important for our clinical field, because we don't have any tools for evaluating this patient should use more than the other one, more use high dose antipsychotic drug than other one. Maybe this helps to us.
So you're actually saying, if I understand it correctly, that those with higher exposome scores might benefit from higher dosages of antipsychotic drugs?
Here maybe it's because.
Do you have evidence for that? Have you tested
no,
it?
no.
Okay.
I speculated in future, not
Yeah,
now.
yeah.
Now is not possible.
No, and if like these beautiful pictures of these circles with these arrows, red and green, and they're also on page 41 of your thesis. Do you foresee, because those are very illustrative, I think, do you foresee that we can have such a figure for an individual patient? So you can see, oh, this one has a very high exposure to cannabis. I can imagine that cannabis you can modify easily. Well, easily you can modify it. Or how do you foresee that?
Actually, we decided to give medicine their symptomatology only, and we don't say if they have higher symptom severity. We say dose. We arrange the dose according to their symptom severity. And I speculated now it is not enough to say this exposome score now beneficial for arrangement dosing, but in future, if we improve this score, maybe we can have the chance for it.
Yeah, so you say it's still too early for clinical application. Okay, well that's clear. And I also wonder, you were mentioning, and you described that very nicely, the difference between external and internal exposomes, eh? And the more general external one and the more specific external ones. Did you now group those all together, or should we study those separate? How do they relate to each other within the exposome score? Could you tell me about that?
Thank you for this question, highly esteemed opponent. Exposome score divided three different components: general external, general specific external, and internal exposome. And we can say drug use is general specific, but air pollution general external. We can divide it like that. And to include the, can you repeat again question?
Well, how do they relate to each other? Could you say something, should we study them separately, like the general, because now you used mainly external specific ones in your exposome score, like the general ones, like pollution, urbanization, you didn't take this into your model yet?
But I think I speculated doesn't change anything, because air pollution is general external, but obstetric complication is internal exposome, and urbanicity also general external. And we can add them, but some of them, when we add some of them, we should be careful about that, because they change depends on population. Some of the environmental exposures are risk factor for some population, but this not risk factor for another population. Also, we only take into account this, and also general or general or internal. I think no differences about that.
I think I have to stop here. Thank you very much, and I'm satisfied with your answers.
Thank you very much.
Thank you very much. The opposition will be continued by Professor Kürşat Altinbas from Mazhar Osman Mood Clinic from Selçuk University in Turkey. Thank you.
Thank you very much. Dear candidate, first of all, can you hear me? Yeah. Dear candidate, first of all, I congratulate for your thesis and nice presentation. And also, I'd like to ask a question about the clinical implementation of exposome score and descriptive diagnosis. It's really interesting that you found the relationship between the exposome score and the functionality, also symptom clusters and clinical diagnosis. So with this context, how do you interpret these findings on the descriptive clinical diagnosis, considering the DSM system?
Thank you for this question, highly esteemed opponent. Actually, when we do this study, we try to not use categorical approach. We try to use a dimensional approach, and also we found that the exposome score also related to bipolar disorder, anxiety disorder, depressive disorder. This shows us this score is not only related for schizophrenia. Yes, when by calculating exposome score, we use this score for schizophrenia risk, but these environmental exposures are also related to bipolar disorder risk, such as we know that migration or anxiety and cannabis use is also a risk factor for bipolar disorder. And we know that high alcohol consumption is also related to alcohol dependence is also, and we try to keep these studies for a dimensional approach, not categorical approach.
So do you think that can we use this approach in clinical practice when we are using these tools to use the clinical diagnosis? So it's in one hand can improve the sensitivity, but what do you think about the specificity of this diagnostic concept? I mean, if we are using exposome score for all clinical diagnosis from this paradigm, and then what will happen? What will happen to the specificity of the diagnosis? I mean, so do you think that can we use this concept, this paradigm in clinical diagnosis?
And thank you for this question, highly esteemed opponent. Yes, you are right. It is, yes, in chapter 4, we found that this score has high sensitivity and specificity ratio, but it is not enough because as a clinician, we always has difficulties about this patient has schizoaffective, schizophrenia, or bipolar disorder. We also can decide this this diagnosis with feature and the clinical process. Not it is not easy to say only examine the patient for 15 minutes to say this is schizophrenia or not. And this is also a psychiatric problem. It's like but we shouldn't, and also we shouldn't do this is this patient has anxiety disorder and whole life they have only anxiety disorder. It is not true, because this continues and change by time, and we should be careful if this young person has anxiety disorder. We should aware about maybe in future he has or she has different psychiatric problem.
Okay, thank you again for your answer. Well, I will go for with my second question with the Kraepelin dichotomy, referring the categorical diagnostic distinction between the schizophrenia and bipolar disorders, mood and psychotic disorders in generally in DSM system. And we know that data from the recent studies indicate that there is a clinical and also a neurobiological or genetic overlap in a continuum, as you mentioned and emphasized, between mood and psychotic disorders, chronic major psychosis. So what do you think that, I really wonder your comments on Kraepelin dichotomy from the perspective of exposome score. Should we put all diagnoses in one dimension, starting from unipolar depression or major depression to schizophrenia in the same line, considering the exposome scores? How do you implement these scores to all major psychotic disorders with considering the Kraepelin dichotomy?
Thank you so much for this question, highly esteemed opponent. And yeah, Kraepelin divided two groups, schizophrenia and bipolar disorder. And after that, nowadays it changed. Also, I believe that it changed because, yeah, divided this psychiatric disorder as schizophrenia, as bipolar disorder, saying it is not easy because some genetic, they have some common gen, they have some common environmental exposures for risk for them, and also I can say bipolar disorder and schizophrenia has giving, for example, the amino acid O gene and COMT gene are common for risk for psychosis, schizophrenia and bipolar disorder. We know that, and we can say yes, it is maybe practical for in clinic, but as a researcher, also I believe that as a clinician we should keep in our mind they can be continue, and if one day we can see bipolar disorder patient, we should keep it in our mind. Maybe in future it change, the diagnosis can change.
So if I understand correctly, you mean that this exposome score paradigm will change also. It's against the Kraepelin dichotomy, and maybe we are coming to the end of the Kraepelin dichotomy, as I understand clearly. Yeah.
Sorry. And for exposome score, we try to, I mentioned before, we try to not using this dichotomy. We try to use the symptomatology, and we try to use broad psychopathology, and we accept psychiatric disorder has pluripotency.
Okay, thank you for your answers. I'm satisfied. Thank you.
Thank you.
Thank you very much. The position will be continued by Dr. Umut Kirli. He's an assistant professor at the Institute of Drug Abuse of Ege University, and he was also a member of the assessment committee. Dr. Kirli.
Thank you very much. Is my voice clear?
Yes.
Okay. I can congratulate the candidates and the supervisors for this very innovative work, and it really contributes to psychosis epidemiology studies, as I do, and high risk for psychosis literature, as well as mental health literature in general. And doing this while also doing clinical work is really of value. I congratulate again. My first question is a broad one. I work in a drug abuse institute and see a lot of stimulant use patients, sometimes more than cannabis use. I mean, methamphetamine and the others, and they are causing psychosis more than cannabis. It's just a clinical observation, not a research result. I wonder if we add some more relevant variables to exposome score, such as stimulant use or neighborhood level risk factors, such as social disorganization or something else. What would the advantages for the exposome score be, and what would the disadvantages be?
And thank you for the question, esteemed opponent. And yeah, this is a really good question, because we think that we can add also tobacco use, methamphetamine use, the other substance use for estimating exposome score. But yes, they can improve the effects of exposome score, but also they have some disadvantage, such as they correlate cannabis use strongly, and maybe this cause overestimation for estimating exposome score. And maybe as a first, because it changes also depends on population, as a first, we should calculate their correlation. If their correlation is too much high, we can keep it in mind, and we should say this is not good for adding. But I agree with you, we should add methamphetamine use, the other substance use. But as a first, for avoiding these disadvantages, we should calculate their correlation, because maybe their correlation are strongly, and we should avoid to add them.
Thank you. I'm very satisfied with this answer. And my second question is a brief one. In chapter 5, I guess, exposome is associated with social useful activities and social relationships domain of functioning, but not with self-care and disturbing aggressive behavioral domains. It's associated with two domains of functioning and not associated with two domains. Could you comment on this finding?
And thank you for this question, esteemed opponent. Actually, yeah, this seems strange, but when we look at our results in this study, this result have consistency, because self-care and disturbing and aggressive self-care, this data set includes first episode psychosis, and we know that self-care disrupts can occur later than occur personal and disturbing in personal and social relations. And as a first, we expect from first episode psychosis patients their personal and social life disturbs before disturb in their self-care. And we found that also this symptom severity for aggressive disturbing dimension of this scale, and we don't find the association between exposome score and positive symptom in the PANSS. And we can say maybe yes, this is correlated with personal and social life disturbing and the other parts of functioning, but not parts of symptomatology in this for this scale, because this scale has four different dimensions, and two of them we found that the association with two of them, but we don't find the association two of them. Also, we don't find the association with PANSS score. And this is, maybe we can say, disturbing and aggressive behavior is really related to PANSS positive score. And we don't find the association with also PANSS positive score. And maybe we can say, yes, it looks strange, but it is consistency with our other results.
And the time by the score exposome score interactions showed that PANSS score improved with differentially by the exposome score. It makes sense. It makes sense. It's clear. So thank you very much. Maybe if we have time, I can have one more question, but now it's okay. Thank you. I'm very satisfied.
Thank you very much.
Thank you very much. The position will be continued by Professor Jacqueline Strick. She's a professor of child psychiatry at our university, Maastricht, and she was also a member of the assessment committee. Professor Strick.
Thank you, Mr. Prorector. Dear candidates, I also would like to congratulate you on this great thesis, also your promotion team. I think it's very important to look at environmental factors in a broad way and to use it for screening and also for prevention in later life, we hope. So I was very interested and was very happy to read it. I want to ask you a few general questions about the construct of the exposome. And I would first like to address statement 9. And I wondered whether one of your paranymph could read the statement.
Yes.
I have the... Yes.
The exposome score for schizophrenia, created by adopting the exposome paradigm, helps researchers the effects of environmental exposures on mental health outcomes. It will also have an important place in the future for clinicians to evaluate the risk of psychosis or psychosis in clinical evaluation.
Thank you very much. So you state that you want to use the exposome in clinic for a first episode of psychosis. Now, also, I read in your thesis, and you already stated it earlier, that you can use the exposome for other kinds of mental dysregulations. So I wondered whether the statement you should perhaps alter in first mental decompensation or a more general decompensation than just a state that you want to screen for first episode of psychosis.
And thank you for this question, highly esteemed opponent. I mean that I think you asked me in first episode psychosis, in clinical practice for first episode psychosis, we need some differences for evaluating exposome score or not. Can you repeat again?
Yes, you state that you use the exposome for psychosis screening or for development of psychosis. But I think you stated earlier that you can also use the exposome score for other mental disorders, like depression or anxiety or bipolar disorder. So I wondered, can you not say that you can use the exposome for all kinds of mental disorders?
Thank you for this question, highly esteemed opponent. Yes, this exposome score in chapter 4, I think, we found that this is association with other mental outcomes and mental disorders, mental states also, such as neurotic, such as suicidal behavior. And yeah, for that, we think that we can use it for in clinical practice, but we should improve this score for it, because in chapter 4 we found that positive likelihood ratio for approximately 4 and negative likelihood ratio is approximately 0.2, and it is not enough to say, because we need to use it for in clinic. Positive likelihood ratio should be more than 10. And we can say this scores, yes, this score has some beneficial for this diagnosis, not diagnosis for discriminating or because the association are strongly, but for saying this, for using really clinical practice, we need to improve this score for all things. But generally, we don't think this suicidal behavior or this neuroticism is not related to environmental exposures. We don't think about that too much, because generally psychiatrists think that these environmental exposures generally related to schizophrenia or most severe outcome disease, such as disorders such as schizophrenia or bipolar disorder. But this finding shows us it is not related to only these disorders. It is also related to psychiatric states, psychological states, and maybe we can say not only for psychiatrists, because the other ones, also psychologists, maybe they should keep their minds as a first examining the individuals. They should ask these types, risk factors they have in their life or not.
Okay, yeah, that's clear. Thank you. And also, I'm working with children with mental disorders in the hospital. So I wondered, is it possible for me to use this exposome also in children? Or do you think there's a certain age that you have to have before you can use this?
Actually, exposome capture, thank you for this question, highly esteemed opponent. Exposome captures from perinatal period to death. And yes, we can say we can use it for also children or also babies, also perinatal period, because if someone has obstetric complication in their pregnancy, and we should keep in our mind they can have some problems, some psychiatric problems, or some physical problems in their life, and maybe we can record our data for it, because we can ask this type of question, but not generally they are retrospective. Maybe we can work with other departments like obstetric and gynecology departments for recording this data reliably, because generally we ask this type of question retrospectively, and they can remember that wrongly, or this data can be have some problems. Maybe we can, as clinician, we should work for the other departments. Also, we should like a mental health department also, and also population health department. We can work and we can keep our data clearly, and this helps us and in individual level and in population level.
Okay, so we think you can make a prospective study then with us.
Yeah.
For example, if I have, can I ask? I think that so in this exposome you also included early life events like abusement and so on. I think that the earlier a life event occurs in life, then the more risk it can bring for development of mental disorders. So I wondered, would it be possible to include the factor age or time in your exposome construct?
Thank you for this question, highly esteemed opponent. Using exposome score, yes, we also validated this score for between the individuals between age 18 and 65. But we can implement it for children also, but we should keep it in our mind, because the children risk factors may be different, and as a first we should calculate the environmental exposures weight again for children. If we do that, we can use it, but children is not like a adulthood, because they have different lifetime periods, adolescent and primary school time or before primary school time, and we can maybe divide them like that. After that, we calculated their this environmental exposures weight for them, and we can use it, and maybe we can add some environmental exposures to while estimating exposome score. Maybe we can remove some of them, such cannabis use for primary school.
Yes, because I think, and I think my colleague can prove that first episodes often occurs at the age at 15, for example. So I think it would be, so do you think that you can use it prior before that? So in this way, as you described now?
Yeah, thank you for this question. We can use it, but before 15, we don't use it before, but we can say if we take into account these differences, and these differences depends on age, we can implement it, such as maybe before 15 years old, and also cannabis use age depends on population change, depends on population. In Turkey also the cannabis use age is very low, maybe compared to other countries, but maybe in population level we can keep we can take into account this type differences between age and between after divided age. And we can say, yes, we can use this environmental exposure for children, and the other one is not related to psychosis risk in children. And maybe we can estimating again this weights, these coefficients, and after that we combine them.
Okay, yeah. Thank you.
Thank you so much.
Answers.
Thank you very much. The opposition will be continued by Dr. Gabriela Blokland. She's assistant professor at our Department of Psychiatry and Neuropsychology at our University, Maastricht. And she was also a member of the assessment committee. Dr. Blokland.
Dear candidate, firstly, congratulations to you and your promotional team on a very interesting thesis. My first question is related to the issue of generalizability of this exposome score. So all the studies that you described were carried out in European ancestry cohorts. How might you expect the exposome to differ in other ancestries or cultures even? For instance, would you expect the same environmental lifestyle factors to affect schizophrenia risk in other ancestries and cultures?
Thank you for this question, esteemed opponent. Actually, we discuss it because we know that psychiatric research is only can only captures 10% of genetic research, also captures 10% of the worth, and this is a problem. But in 4 chapter, we adjusted our results also from ethnicity, because our data set consists of 3 different countries: Serbia, Spain, and Turkey. And as a first, while calculating exposome score, after calculating exposome score, we adjusted our data for that, and we tried to avoid to use ethnicity and a minority to calculate exposome score, because our aim was to generalize this score for in general population with low diversity, and because we normally we can add and we have the data, but yes, some of environmental exposures we can add, but some of environmental exposures change also in European countries, such as UK. In UK, living in urbanity doesn't have problem for psychosis risk. Also in Netherlands, but some of the countries, developmental countries, this is a problem. Urbanity, living in urbanity is a psychosis risk. Also, these differences has also in European countries, and maybe we can keep it on mind, but we can use it, but we try to avoid them. We adjusted our data, age, sex, education, and after the education, different countries, we adjusted our data for different countries, and after ethnicity and minority for that, we adjusted for data, but maybe in future, this score can be calculated by taking into account these countries has different environmental exposure risk for schizophrenia, and maybe they can implement it for it. And because yes, this calculating this score is not difficult, but knowing this information about the country levels is not easy. Yes, such as in Brazil, burning in winter is not problem, is not risk for schizophrenia, but for in Turkey it is a risk factor for schizophrenia. Maybe we as a first we should identify this environmental exposure, which environmental exposures are more risk factor in country level. After that, we can implement this score in country level. Maybe it changed because we can have the chance to calculate this score in individual level, and we can implement it for also the other ancestry. But some problem we have, such as they don't have the fund to do this type of research, and we don't have the data about them to use it for this country has in this country this environmental exposure are risk factor for schizophrenia. For saying that it is not easy, and maybe we think about it, but as a first, this is also funding problem. Thank you.
Just as a short follow-up to that, would you expect, so yes, it's difficult, of course, to distinguish these different factors in different countries and cultures. Assuming that you could, would you expect a different interaction with the genomic risk in one ancestry versus another?
Yes, it can be, but we can only solve this problem. I know it is not enough. We can solve only this problem for adjusting this polygenic risk score for it, and we did it in chapter 5, in study in chapter 5, and our results remain same. We only have this data for it, but maybe if we solve this problem for polygenic risk score, maybe as a first, maybe it is better. But after that, as complement of polygenic risk score, exposome score, we can say it is a complement for this score. Maybe we can have the data about that. We can have the we can solve the problem in future. Also for genomic and the other risk factors we didn't calculate it, or we didn't investigate it. Maybe we can solve at the same time with that, because the funding problem is not only related to environmental exposures. Also, they don't have the fund to investigate it, other types research.
All right, thank you. Is there time left? Yeah. My other question was about sex differences. We know there are significant sex differences in schizophrenia in both incidence and presentation and outcome. In most or all studies, you included sex as a covariate. However, I was wondering, how strong were these sex differences that you observed in the schizophrenia exposure score? And in an ideal situation, given a large enough data set, for instance, how might you handle sex differently as a factor in your analysis and possibly beyond in the translation to clinical practice?
Thank you for this question, esteemed opponent. Actually, as you mentioned, we used age, sex, and education as covariate in all our studies, but saying this is enough for this study, it is not enough. We can say it is not enough to understand sex differences, but this score is individual level, and maybe we implement this score. We wait, yes, cannabis use is more related to psychosis in women than men. We know that also. Some of the environmental exposures, such as season of birth, such as urbanicity affect men more than women, such as birth of season is the similar effect for men and for women for psychosis risk. But some of them, they have differences, like a childhood adversity also, Also, urbanicity affects man more than women, and maybe yes, we can keep it in account. We use these coefficients from meta-analysis based man. Maybe if we find that meta-analysis includes these sex differences, maybe we can do it.
You may surely answer the question if you want. Finish it.
Thank you so much.
Okay, thank you very much. Gamze Erzin, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in the room.
Konuşamıyoruz galiba. Sorry?
This is for the elevation.
Uh-huh.
You can step away from the lecture. It will take about 10 minutes. When the screen changes, you have to go back.
Okay.
So will you use that microphone on for the yes, I promise?
Uh-huh. Ha, gelebilirsiniz dedim. Şu an hiçbir şey anlayacak durumda değilim. Soruların birkaçını anlamadım. Çünkü soru gibi değildi bu anda. Ha, yok, supervisorlar da öğretmenler de yardım edemiyor. Ben birkaç kez söyledim. Özge Türkiye'den de burada bilgisayar bölümünde, bilgisayar mühendisliğinde doktora yapıyor. Emine de startta çalışıyor. Aslında master mi geçtin? Süper. Aslında siyaset bilimi mezunu ama daha çok endüstriyel mühendislik gibi. Laura is from Italy. Yeah, she's my friend from last year. Yeah. She's psychiatrist also.
I am from northern Italy, like 1 hour from Milan, but I'm working in Sicily, in southern Italy. Yeah. Yeah, but originally from the north. Nice place.
Şimdi mi? Yok, gerek yok bence. Şimdi herhalde gitmek de birazcık olabilir, biraz uzak olabilir. Evet. Çünkü ikisi klinisyen, daha çok researcher'dan. Two of them are clinician more than researcher. One of them she's statistician. Yeah. Gabriella. And Gabriella's question is like, yeah, and I got tired and I know how to respond her question, but I got tired and I'm good for it because normally after 20 minutes, after the presentation, 20 minutes, I got tired and I said, no, and I always prepare my presentation for 10 minutes for it.
Then it was like 14 minutes. So,
Yeah.
No, I think, no, I think that yes.
I think Sinan and Bart arranged them. 12 them. I need them, but their questions are not.
You don't know them before.
No, I know them. They are not my friends, but I need them. They are psychiatrists also. One of them in Izmir, one of them in Konya. Yeah. Ege University, Umut, the right one. Ege University, which and dependence department, not psychiatry department. But he's also good clinician. Yeah, he's psychiatrist also, associate professor, but now he found the position at this department. Yeah, we don't know, but also he can also examine the psychiatric disorder, patient anxiety, psychosis, depression. Not only alcohol or the other departments, because in Izmir, not so much.
That was my psychology. He's a professor.
He's psychologist. But there are a lot of because people generally want to live in Izmir. And really propranolol works. Really propranolol works. Propranolol Liberal I used. Yes. Okay. Normally I don't use.
Presentation speech and then presentation. But when did you say? Because I was not here, so that.
No, you can use whatever you want. Yes.
For each department or for your department?
No, every department.
I also can prepare myself. Right?
Yes, you can. Do you have any idea about it? Yes, they are coming.
Gamze Erzin, the degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Dr. Guluxus is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Do you promise the work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Thank you. Yes. Yes. I promise.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Gamze Erzin, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
You can do the laudatio.
Gamze, congratulations. You made it. I clearly remember the first time I heard your name. It was some 6, 7, maybe 8 years ago. My eternal mentor, Timothy Noral, sent me an email to provide feedback on one of your papers. I guess it was a research about the inflammatory markers in bipolar disorder. And years have passed, and this time you approached me to seek my mentorship in your academic psychiatric career. And your PhD journey in Maastricht started. Your first achievement in this journey came very quickly. We wrote a grant application to study exposome score for schizophrenia and to support your visit here, and boom, TÜBİTAK funded the proposal immediately. Things were going very fast, but also very smooth, well, until it lasted. Then came the pandemic that changed all of our lives. Everything was surreal and very frightening, like an apocalyptic sci-fi. And life literally stopped, but there has always been sunshine after dark times, and you know that. For many students, PhD is a transition period, the last stop before adult life, and let alone closing a chapter in your life and opening a new one. You've done this during the pandemic. You've shown the bravery to come to Maastricht, build yourself a life here as a visiting researcher on your own during the crazy COVID times. And don't underestimate these achievements. Even if for a brief period, it's not easy to move abroad and live away from home in a completely new country. Pandemic was harsh for all of us, closures and some relaxation, followed by even stricter measures. And in your brief time here, you witnessed history. The first curfew in the Netherlands since the Second World War. And our homes turned into our offices and everything into virtual and research in the time of COVID. These issues perhaps slowed you down a bit, but couldn't stop you from achieving your goals. Overall, it was a pleasure to supervise you, but I must admit that it wasn't an easy task, particularly early on, and I think Lotta would agree with me on this one. I vividly remember the time that I needed to go over your paper, not once or twice or even thrice, but 6 times. Well, many would have given up at some point early in the process, but I guess I still retain the passion for science and internal drive. But most important, which I always say, motivation is mutual. The more the student motivated, the more the supervisor giving, and vice versa. So thank you for appreciating and motivating us. During your PhD, your academic skills improved and your desire to achieve more in your career has been a major catalyzer for you. Like while working on your PhD here, you went to actually for a brief moment, take a very competitive exam and interview process for psychiatry, for academic posts in Turkey, and you made it. And while at it, you become an associate professor in Turkey. In the meantime, you stacked up papers one on another, and the awards followed the papers. And I must say, it's been an impressive run. The European College of Neuropsychopharmacology Excellence Award, the Schizophrenia International Research Society Early Career Award, the Society of Biological Psychiatry Early Career Investigator Award, and of course, the climax of your PhD work, the best paper published in European Psychiatric Journal awarded by the European Psychiatric Association. I wish we could celebrate this huge achievement, so I could just be there as a proud supervisor at this largest European psychiatric conference. But of course, now we're cursed with this ugly war. It's so unlucky that it's now turned into fully virtual because of the war. And I see you mentioned ice Americano, my favorite drink. It's what a simple to make drink, many would say. And will add, I can do it, no problem. Yet there are many elements. The coffee blend, the amount of water, the amount of ice, and even the type of ice. It's like science, even the simple things require focus and dedication, and hours to perfect. And science is a creative process, just like the pineapple infused ice Americano. And you need to keep doing after perfection. And I think you're now more experienced with the intricacies of research while developing essential academic skills. It is sad to see some academics can't find time from their busy agenda to put into essential work as they become more senior. And then they forget the joy of doing science, and maybe for some, the joy that never happens. Hope you continue to enjoy doing science and really do research and write. And besides being your supervisor, I also would like to thank you as a member of the SERS Diversity Committee for accepting my invitation to present at our workshop, Women in Science, and reflect on your observations about the current state of academia for women in Turkey and the Netherlands at this year's conference, based on your observations. Who knows, maybe someday you'll talk about your experiences as a woman with Turkish background in Germany or the Netherlands. And I hope you will continue to be a beacon for not only women, but also minoritized, marginalized groups. The PhD journey is over now, so kudos to you. But another journey starts for you. You see, we're now here, generations of supervisors sitting, part before me, before Lotta. It is now your turn to pass on what you have learned. I wished I could have made a Yoda impression like Michael Scott, but you get the point. So finally, I've been fortunate to know you and be a part of your academic career. Who knows when and where our paths cross again, but until then, congrats for all your achievements.
Thank you very much. Dear Dr. Erzin, also on behalf of the Board of Deans, I congratulate you with the honor you have acquired. I think you did a great job, and I also ask you to enjoy it. And I wish you all the best in the continuation of your great career, no doubt about it. Before I close this session, a little household announcement. We will have a little picture after closing of the ceremony here in front of the screen, so also with the people from abroad. And also would like to take the opportunity to give you a little present from the university. So that's it for now. Hereby, I close this academic ceremony.